Thank you very much. I'm very pleased to be here. Thank you so much to the Society for the invitation. I always learn more than I feel I present when I come here, so I can't tell you how grateful I am to be here. Our practices, I think, are more similar than different, but what I wanted to do really to begin with is to sort of confirm the terminology between licensure, certification, and competency, and how we have very specific terminology that we use in the states to describe those concepts. What our licensing and renewal requirements are, touch on advanced practice nursing, that sort of could be a whole talk on its own, and then really look at some competency validation that occurs in U.S. hospitals. So I went to the Oxford Dictionary, as Joel Dunning reminds me frequently. You invented the language, we stole it, and changed it inappropriately, apparently. So licensure, really, the definition for that is official permission to do something. My license means I can practice nursing. If I don't have a license, I am sent home. The day my license expires, I am sent home if I have failed to renew it. So this is a requirement that cannot be usurped. Certification, on the other hand, and I thought it was interesting that this was chiefly a North American term, is the action or process of providing someone or something with an official document attesting to a status or level of achievement. So certification is not required. Certification is something that our nurses seek. They become certified in advanced practice nursing, critical care nursing, although advanced practice nursing has licensure requirements as well. So it really is a very different concept. And then last but not least is the concept of validation. And that really is proving or checking that what you said you can actually do. So how does this work in the United States? Well, there really is very little federal legislation that affects me. Right now, there's legislation that just came down regarding prescribing of narcotics because of all the people that are dropping dead of overdoses. And this doesn't affect just nursing. This is all prescribers. So they haven't singled nursing out in this in any way, shape, or form. Very little feedback comes in that way, but what we do get from the federal government is the accreditation process. So the Joint Commission for Accreditation of Hospitals comes around. They have a great deal of regulation that my organization must comply with, but that gets into my competency. They have a requirement for organizations that they hire and employ competent individuals. So I'll come back to that at the end as how my hospital proves to them that I'm competent. So what happens is this really all boils down to the states. We have 50 states, but then Washington, D.C. is sort of like Vatican City. It's all on its own. It gets its own little accreditation there. I think, there are other territories in there. There are more than 50 people represented by the state boards of nursing. They oversee each of these states. So there is one board that oversees what happens, and primarily what their job is to develop the exam and enforce the standards of that exam that every nurse in the country takes. So for new practitioners, that's where the NCLEX and the national board really has their influence. And then you get to what really happens in the states regarding licensure, and that's all by state. It's different. Every state has their own Nurse Practice Act. They set qualifications for licensure and renewal, including how many continuing education hours I need, residency requirements, and security. I had to be fingerprinted to get my license in the state of California. So how do I know if I'm coming to the state or I'm transferring to another state? Does my license transfer? Do I have to jump through hoops? What do I need to do? Well, if you go to the national board of all these state nursing, they point you to the Nurse Practice Act Toolkit, and basically it says, find your Nurse Practice Act. So you put in your state, and then it jumps you to what your rules and regulations are. And again, if you read what it says, the practice of nursing is a right granted by each state, and their job is to protect the patient, to make sure that safe, competent nursing practice is grounded in the law as well as their own state statutes. So in order for me to go from one state to another, I would have to get a new license for every state that I go to. This map shows you where I am. It also shows you how many licensed nurses there are in the United States. 3,700,000 as of 2016. Excuse me, that says last updated, yeah, that was January of this year. So in the state of California, where I am from, there are over 300,000 registered nurses. You can see the graph here. We're growing by leaps and bounds. And you can see from the state here, of course, we've got the cream of the crop at the top, with San Francisco being well represented. But by and large, the big pockets of nursing are separated in those two regions. Southern California around Los Angeles, San Diego, and then the northern part of the state. We have exactly the same rules and regulations that we must all follow. And we're suffering from the same issues around the country as we are in California. We've come through a wonderful rebirth of the need for nurses. Within the last 2 years, the demand for nurses has gone through the roof. The recession and the economy really caused a lot of havoc with this in the States. A lot of nurses that were coming out of nursing school could not find jobs. They were taking nursing aid positions and other things in order to seek employment. That is gone in the United States. So if I wanted to go to the state of California, I would go to the California Board of Registered Nursing, get this wonderful picture of Jerry Brown, my governor, and I need to get a license from this state before I can practice. And unfortunately, the requirements for each state vary. And this approval process can be fast or slow. It's gotten better as things have been more automated. But again, every one of these states has different rules, but they all will give you a message, something like this, that they're trying to protect the public by ensuring the highest quality of nurses are registered in the state of California. So we're all getting older. I thought I would go ahead and point this out. Almost half of the nurses in the United States are now in California. It holds fairly true for the rest of the country, are over the age of 50. 12% plan to retire in the next 5 years. We are predicting big shortages in our country. I found this picture on the internet. This woman is 80 years old, and she's getting ready to retire. I think that sounds like she's earned it, if you ask me.
She looks like she works at the QE.
I didn't want to speculate where she might work. So when I went in to sort of get some information for you about, what are the licensing requirements by state, again, what you can see here is that there's quite a bit of variability in terms of frequency. Arizona requires you to get your license every 4 years. Connecticut requires it every year. If you look at fees, the least expensive are $50. These are U.S. dollars every 3 years in New York. That translates to $75 every 2 years in Alabama. The most expensive is in Alaska, where they charge you $175 every 2 years. Continuing education units, and we use the terminology here, so for every 50 minutes of education, that equals one continuing education unit. And most states require 12 to 15 continuing education units a year. My state requires 15 a year. No continuing education requirements exist in 17 of our U.S. states. So again, you're seeing tremendous variability here. Work requirements, very rarely are they even mentioned. You can go for a long period of time, and as long as you renew your license with continuing education, most states will allow you to do that. And then some states really require that you have very specific education. You must submit 4 continuing education units on infection control or HIV or abuse or something of that nature. So this has taken on a life of its own in the United States. Ongoing licensure is required for, continuing education is required for licensure in so many states that what we see is that this has really become a business. And although you see this, free continuing education courses, nothing in life is free. And so these websites exist. Nurses may find themselves in this situation of, oh my goodness, my license is due in a week and I haven't kept up with my continuing education requirements, and then they go online and they look for things like this. Or they may find other courses, and you can see, there's renal failure, physiology, But we, being the United States, also now have medical marijuana and cannabinoids as something that you can pay, $19 and get 5 continuing education units for. And then, not to be outdone, you can take a cruise and get your continuing education units as well. So again, this has really become a business. My hospital offers free continuing education units to our nurses. I put on many of those courses, but there are many of them that go to the outside for these sorts of courses, and our employers do not require that those courses be of any certain content. How do you know with this system if someone has a valid license or not? It's all online. It's very easy to find out. And the day that my license expires, I assure you, my employer knows it, and they send me home from work. So no one is allowed to work with an expired license. Now, when we look at advanced practice nursing, I think we in the United States are a little bit different, and then a master's degree is required in order to be an advanced practice nurse in the United States. And there have been some recent changes in years to this taxonomy that you're looking at here. You can see that within the confines of an advanced practice nurse, we have nurse practitioners, clinical nurse specialists, midwives, and nurse anesthetists. So those 4 categories are all included. The nurse practitioners, you'll notice on here, nowhere does it say acute care nurse practitioner. And I work with a huge cadre of nurses in our ICU units who put in tubes, intubate patients, run crises, write orders. So, within this rubric, there have been some changes. And what happens within each of this education, again, this is the master's preparation, there are clinical hours that are required to get your master's. And so where you spend those clinical hours is really how you kind of get the essence of where you want to be performing afterwards. That being said, I will tell you every one of our ACNPs that comes aboard has a pretty steep learning curve if they've not been an ACNP. And in fact, we're a quaternary facility. My unit does ECMO and liver transplants and all kinds of things like that. So even people who have been experienced ACNPs come to our unit and get a bit of a shock. And there's always some orientation that needs to happen. With a clinical nurse specialist, it's the same requirement for a master's degree, but my clinical hours and my focus was quite different. And so while the nurse practitioners are really focusing on direct patient care as their sole reason for being, mine is really a systems approach. And our clinical nurse specialists, you will see a great deal of variability in how that role, as you shared, JP, it's exactly the same thing. I, in my role, work quite differently than our woundostomy clinical nurse specialist, who's almost entirely patient-focused but sets up systems of care for wound management and ostomies, whereas I'm really about setting up systems of care previously for our cardiac surgery patients. So my role was outlined here. In order for me to be licensed in the state of California as a clinical nurse specialist, and I must have a license to use that title, I need to demonstrate skill in all of the areas that you see here. And so I need to demonstrate expert clinical practice, education, research, consultation, and leadership. If I'm a new nurse that's going through their master's program, I need to have my clinical hours signed off on someone that's been my preceptor. I am typically the preceptor. So I fill these forms out for nurses that spend time with me that want to be an advanced practice nurse. So that's the licensure piece of it. Now let's talk about certification, because this is a really different animal. Really, we're talking about, attesting to a status or level of achievement. The American Association of Critical Care Nurses has done quite a bit in our country, probably the organization that represents cardiac surgical nurses more than anyone else. This is a process by which a non-governmental agency or an association grants recognition to an individual who's met certain qualifications. This can be used for entry into practice, for validation of competence, recognition of excellence, and/or regulation. It can be mandatory or voluntary. It validates my knowledge and skills in a defined role, clinical practice area, based on predetermined standards. There are hundreds of specialty organizations right now in the United States. You can become certified in woundostomy, cardiac surgery, critical care. Again, the largest specialty organization in the United States is the AACN with over 100,000 members. So they have a subspecialty certification in cardiac surgery, and if you wanted to learn more about this, you would go to their website, and there you can learn what you need to do. You need to have an unencumbered state license. You need to have some other specialty. So you can do this after becoming an AACN certified nurse or some other specialty. It doesn't have to be critical care. They do have practice requirements, and here you see what they are, and they specify that that must be in a cardiothoracic intensive care unit in order to get this certification. You have to have verification of practice, and the exam itself takes 2 hours, has 90 questions, and depending on whether or not you're a member of this organization, you get a different fee. The other cardiovascular surgery specialty certification is through the ANCC, American Nurses Credentialing Center. They offer hundreds of certifications through this organization. You must have a current license, 2 years practice as a registered nurse, and then within the last 3 years have put in 2,000 hours in cardiovascular nursing. The exam is more lengthy, as you can see here, a bit more expensive. And this certification process is really, again, sort of becoming something that the organizations are touting and organizations are acknowledging. So, for example, in my own organization, we are trying to encourage nurses to become certified. We will offer tuition reimbursement for this. They get so many hours off work in order to achieve this. And one of the reasons that we do that is that it has been shown in numerous research studies, this is just a small example, that certified nurses provide better studies here. There was the first that's been documented by Boyle in 2014 in a surgical nursing journal showed that higher rates of perioperative certification, peri-anesthesia nursing, operating room nursing were significantly associated with lower rates of central line bloodstream infections in the surgical ICU. In another study in pediatrics, Professor Hickey identified that their children's hospital cardiovascular surgery database that includes 38 hospitals identified that your odds of death increased as the institutional percentage of pediatric intensive care unit nurses with less than 2 years clinical experience increased. That credential, CCRN, was associated with decreased odds of death. And why would this be? You've sort of separated yourself out as someone who wants to take that extra step. It's not required. It's an extra step. So now last but not least, I'd like to come to the concept of competency. A competent individual is someone who has the ability to do something either successfully or efficiently. And validation then is proving that. Who does that in the United States? It's the Joint Commission, the accrediting body for hospitals. And this is their language. Competence assessment lets the hospital know whether its staff have the ability to use specific skills and employ the knowledge necessary to perform their jobs. So my employer must document when the Joint Commission comes in 2 weeks, I'll be there, that all of their employees know what they're doing. This is how we do that in my hospital. There's a great deal of variability, but it's all generally the same sort of idea. We've got competencies that are based on the unit that the nurse is working on. So this is an annual competency for a nurse that would be working in one of our critical care units. They must demonstrate knowledge of pressure ulcer prevention, pain, sedation, and now we're getting into some of the specifics of our critical care unit, CRRT, balloon pumps, VADS, ECMO, et cetera, et cetera. Not all of our nurses take on this the first day that they arrive in our unit. Some of them may not have these skills and would not be anticipated to care for a VAD or ECMO patient until they've been there for a year or more, and so that would be grayed out for them. That would not be a requirement. We need to demonstrate, so typically a nursing educator, a charge nurse, or a manager would ensure that this gets documented. Let's talk about something like this. Demonstrates management after cardiovascular surgery. What on earth does that mean? That's quite broad. I can imagine a regulator saying, what does that mean to you? Here are the critical elements that I wrote to define what our postoperative essentials are. And so our nurses need to demonstrate these things. Some of them are done very directly with a return demonstration, such as defibrillation. Others are things that they can take an online module for and verify. And we actually have a great deal of our education offered that way via a system called HealthStream. And it's an online education system. All of our nurses are required to do it. It links into their licensure. And so when they take continuing education courses, it automatically shoots over to their license. And so when we look at something like this, verbalizes understanding of resuscitative measures, this is CALS. This is what we teach to our nurses. And so in that instance, this is an all-day course that they must come and attend. So to meet that competency requirement for cardiac surgical management, they must go through this course annually. We offer it to our nurses at no charge. It's one of the few things that is offered to them at no charge. On our ward area, we do not require our nurses to go through the entire CALS course, but what we do is have a standardized procedure for them to both recognize dysrhythmias and troubleshoot them not only with defibrillation, but with temporary pacing strategies. What about me? How do they validate as a clinical nurse specialist that I'm competent to participate in patient care? It's much more vague, as you can see here, the same categories that I talked about before in terms of clinical practice and consultation, I need to demonstrate evidence of. How do I do that? This is really the fuzzy one. This is one where your manager or supervisor or a colleague or peer signs you off. So I still have continuing education requirements. This is my in-hospital validation that I'm a competent clinical nurse specialist. And I can add to this and add supportive information to make the case, but generally this is not really a concern. The last thing that I wanted to mention is that with so many nurses leaving the bedside, if you will, to develop, education and leaving the hospital, we realize we desperately need experienced bedside nurses that stay there, that don't leave to become academicians. And so this clinical ladder concept is one that most hospitals employ, and it's set up to really allow staff nurses to do some of the similar work that you've talked about in order to be able to progress within a merit system within the individual hospital. So in order for a nurse at my hospital, and again, this is quite similar with models around the country, if that hospital has a clinical ladder, and they don't all do, I need to have a professional certification in my area of specialty, a minimum 2 years at my facility with 1,000 hours in, and greater than 75% in direct patient care. I must have a position. I must have a bachelor's and have 4 years prior experience, or an associate degree in nursing with 6 years prior experience, and my appraisal must be a strong performer, and again, 10 continuing educations in my specialty area. Here's where the portfolio comes in. So for me to sort of go to my employer and say, I want to go in the clinical ladder, I want to become a clinical nurse 3, we don't have bands in the United States. We have registered nurses and advanced practice nurses, and that's it. So this is sort of how we've created a band system in our own country. And then there are monetary advantages to this. You get a higher hourly wage if you've gone through this process. So you have to write goals, you have to keep them up, you have to participate in professional activities. Your clinical exemplar, exactly the same as your reflection. We have a chart review requirement where we actually go through and pull little snippets from our documentation, where we're asking them to show exemplars of their documentation, and that needs to be submitted prior to a panel interview. So licensure and certification and competency, what's the important connection here? It really is ultimately about protecting patients from substandard care. Obviously, I think there's a higher rubric here. A nurse that becomes certified is really going above and beyond that basic minimum standard. But the bottom line, if you look at the certification requirements, the goal is always to be focused on the patient. And I do believe that the evidence is showing us that as we move further down this journey, patient care will improve. So again, in summary, licensure is required at a state level, which creates significant issues of portability for our nurses, and some variability in performances as well. Certification is really managed by professional societies and companies who do those professional hours, and virtually any sort of certification is available in the United States. Competency validation is a federal requirement, and so our hospitals ensure that we can meet that. And clinical letters are something that may or may not exist in an individual hospital in order to support excellent nursing practice at the bedside. Thank you so much for your attention, and I'm delighted to take any questions that you might have before I catch my train.
Thank you very much.